In a patient with pneumothorax, what you are going to get? You are going to get a barcode sign, right? Now, moving on to the next question. A 42-year-old female presented with pain in the right upper quadrant on the 5th post-operative day, following laparoscopic cholecystectomy. She is icteric. On ultrasound, there is fluid collection in the Morrison's pouch. A biliary leak is suspected. What is the investigation to detect this pathology? Right? So there is collection of fluid in the Morrison's pouch. What is Morrison's pouch? It is the space between the liver and right kidney. Right? It is the most dependent part of the peritoneal cavity. If there is any fluid within the peritoneal cavity in supine position, it is going to collect in the Morrison's pouch. So very nicely answered by Ayush Tiwari. The answer is HIDA scan, right? So for any biliary pathology, most of the biliary pathologies, the gold standard, okay, the gold standard investigation of choice is HIDA scan. So what happens in HIDA scans? The patient is injected with a radio tracer agent, that is immunodiacetic acid. And this radio tracer agent, it will be excreted within the biliary tract, right? And if there is any injury to the biliary tract during the surgery, if there is any injury to the CBD or your common hepatic duct, that is going to be excreted within the Morrison's pouch. That will be excreted, and that can be picked up on the HIDA scan. So if I'm going to ask what are the other investigations, where your HIDA scan will be the investigation of choice? Anyone? Other investigations where your HIDA scan will be the gold standard investigation of choice? Anyone? So HIDA scan will be seen in patients with, will be the investigation of choice will be seen in patients with biliary atresia, in patients with acute cholecystitis. Your HIDA scan will be the investigation of choice, right? And these are the two important indications. Now let us talk about MRCP, right? So what is MRCP? What does MRCP stands for? It stands for magnetic resonance cholangiopancreatography. So these are nothing, these are but your heavily T2 weighted images, and we all know what happens in T2 weighted images. The fluid appears white on T2 weighted images. So basically the bile that is present within the biliary tract, the pancreatic juice that is present within the main pancreatic duct, that will be very easily visible on the T2 weighted images, that is your MRCP images, right? So just remember that your MRCP is the investigation of choice in patients with choledocholithiasis. So it is a very good investigation to pick up stones within the CBD, to pick up stones within the gallbladder, right? It is a very good investigation to look at your main pancreatic duct in patients with chronic pancreatitis, right? In patients preoperatively, we can get this investigation to look for any abnormal biliary anatomy. So sometimes what happens, there is a medial insertion of the cystic duct. There is a medial insertion of the cystic duct, and what happens whenever there is a medial insertion of the cystic duct, the patient during the operation, the surgeon can injure the CBD, right? Injure the CBD whenever there is a medial and low insertion of the cystic duct. Sometimes what happens, the right posterior duct, it joins with the cystic duct, or it is joining lower down into the CBD, And what happens in this case, you have to mention these abnormal biliary anatomy to the surgeon, because while operating, what he can do, he can injure the CBD or the biliary tract of the patient, and that can result in leakage of bile, and that can result in fluid collection, right? So a 55-year-old patient with history of peptic ulcer disease has had abdominal pain and distension for many days, right? Physical examination shows abdominal guarding. Abdominal radiography is shown below. What is the important next step in the management of this patient, right? So what have been shown to us? Anyone? So we have been shown to us an abdominal radiograph. And what is this abdominal radiograph showing? We can see, guys, that there is free gas under the right dome of diaphragm, and this is seen in a patient with pneumoperitoneum. So what happens whenever there is any injury to the bowel, or whenever there is obstruction, your bowel loops, they can get a rupture because of the increased intraluminal pressure. And whenever they rupture, what happens, the gas within the bowel loops, that comes into the peritoneal cavity. And when this gas comes into the peritoneal cavity, on supine X-ray, on erect X-ray, you can see it. You can see this free gas under the right dome of diaphragm, right? So whenever what will be the investigation of choice? You are going to go for IV fluids and exploratory laparotomy. So if someone would have asked what will be the imaging investigation of choice, so I would go for NCCT abdomen with oral positive contrast. So when I give oral positive contrast to the patient, what it is going to tell me, I am going to come to know about the site of injury, okay, the site of rupture. Because of the leakage of contrast, I will get an idea about the site of rupture of the bowel loop. So that can be done before going for the operative management. A 40-year-old male patient with true history of mucopurulent cough underwent a CT chest. CT scan is shown below. What is the most likely diagnosis? Right, the most likely diagnosis in this case, what we can see, we are getting a signet ring appearance. So in a normal patient, what happens, the ratio of pulmonary artery to bronchiole is more than 1. So if the ratio of pulmonary artery to bronchiole is less than 1, it means that the bronchioles, they are dilated, and these abnormal dilated bronchi, we call it as bronchiectasis, right? So here in this patient, we can see that this abnormal dilated bronchi, they are giving a signet ring appearance, and this signet ring appearance, this is seen in patients with bronchiectasis. So let me give you one important question related to bronchiectasis that is very frequently asked. So the patient has history of asthma, right? On CT images, you are going to see central bronchiectasis. The patient has history of asthma. On X-ray, you will see that there is a finger in glove appearance, and this finger in glove appearance, this will be seen in patients with allergic bronchopulmonary aspergillosis. Now, a 24-year-old male patient comes to the office to evaluate sneezing, cough, fever, and pain behind the eyes. He is being diagnosed. He is being diagnosed with sinusitis. The radiograph shown below is better to assess the frontal sinus. Okay, so guys, for frontal sinus, just remember Caldwell's view is the best view to assess the frontal sinus, right? Waters view is best to assess your maxillary sinus. Just remember these two important views, right? So another one-liner question. A 54-year-old patient came to the OPD with extreme pain in all body joints, fever, and history of weight loss. He is diagnosed with a metastatic bone cancer. Which of the following will be done to confirm the bone cancer, right? So guys, remember all the bone forming tumors, they show increased uptake on methylene diphosphate scan, okay, which is nothing but your bone scan. So any metastatic bone cancer, that is going to result in increased formation of the bone, right? And if I'm going to ask you one very important question, which are the tumors which are common in patients with more than 40 years of age? So you should remember that three important tumors. One is chondrosarcoma, that is common. Then you will have multiple myeloma, again common in more than 40 years of age. And third is metastasis, right? And if I talk about metastatic bone tumors, so the tumor which is associated with sclerotic lesions, the most common bone tumor which is associated with sclerotic lesions, that is your prostate carcinoma, right? Most common tumor in females associated with bone mets will be your breast carcinoma. Most common tumor in males associated with lytic bone mets, that will be your lung carcinoma, right? Also you get important typical appearances like your cookie bite metastasis. This is seen in patients with lung carcinoma. You have blowout mets, that is seen in patients with renal cell carcinoma and in patients with thyroid carcinoma. So these are few important questions that you need to remember as far as bone metastasis is concerned. Identify the name of the investigation, right? Very simple question if you have seen this image before. So this is an ultrasound image of thyroid gland. MRI you all know, okay? It is you must have seen MRI of the brain, of the joints like your like your shoulder, knee, right? And what you can see, this is the thyroid gland. You can see the vessels here. This is your common carotid arteries, right? And this is your trachea. So simple investigation. This is the ultrasound of the neck, right? Which of the following statement is true regarding corads? Okay, so talking about 0, okay, so let us talk about what are the most important imaging features. Most important imaging features as far as COVID-19 infection is concerned. In the imaging features which are typical of COVID-19, right? So you will go for an NCCT test in these patients, and within the NCCT test, if this is the test, what you are going to see, you will see areas of peripheral ground glass opacity. Peripheral areas of ground glass opacity will be seen in this patient, right? Peripheral areas of ground glass opacity will be seen in these patients, right? So this is the most important imaging features of a patient with COVID, with typical COVID-19 infection. Now if I talk about CORADS 0, okay, it is not CORADS 0 which is a normal lung, it is the CORADS 1 which is a normal lung. So first option is ruled out. Talking about CORADS 5, CORADS 5 is typical of COVID-19 infection, right? Talking about pleural thickening and lobar consolidation, these are not features of patients with COVID-19 infection. Now guys, identify the anatomical variant shown in the CT scan, right? So in this image, what we can see, this is your superior turbinate. Now normally what happens, this superior turbinate will appear as a single bone, right? But here you can see that there is air within the superior turbinate. Air can be seen within the superior turbinate. So this presence of air, the presence of pneumatization within the superior turbinate is what we can see in the given CT image. Now talking about Onodi cell, right? So Onodi cell, these are your sphenoethmoidal air cell that are going to lie adjacent to the optic nerve. So here in this image, we can see Onodi cell can be seen, and you can see that this part is your optic nerve. You can also see one foramen here, right? So this foramen is your foramen rotundum, and through foramen rotundum, what nerve is going to pass? Your maxillary nerve is going to pass through this foramen rotundum, right? And what are Haller cells? If I talk about Haller cells, okay, so if this is the orbit, you are going to see that Haller cells, they are going to lie along the infraorbital margin. They are also known as infraorbital air cell, okay. So this cell which you can see just inferior to the orbit, this is your Haller cell. Right? So let me teach you few important anatomical structures in this PNS anatomy. So this is your frontal sinus, which you can see. Then you have your middle turbinate. So normally what happens, this middle turbinate, okay, these are curved outside, okay, they have a curvature that is facing outwards. But here in this image we can see that this middle turbinate, it is curving towards the nasal septum. So when this happens, this is a case of paradoxical curvature of middle turbinate. middle turbinate, right? And all this maxillary sinus, okay, then your frontal sinus, anterior ethmoidal air cells, all these are going to open into the middle meatus, right? 65-year-old non-smoker presented with nasal blockage and occasional mixed nasal discharge with the following radiological and endoscopic findings. What is the likely diagnosis? So guys, in this patient, what you can see that there is a tumor that is present within the maxillary sinus. The tumor is present within the maxillary sinus and it is extending into the nasal cavity. And the kind of appearance, you can see that there are areas of hypointense bands within the tumor, and this type of appearance, it is giving a cerebriform pattern. So this cerebriform pattern of seen in the maxillary sinus, tumor in the maxillary sinus extending into the nasal cavity, it is characteristic of inverted papilloma. Okay, so esthesioneuroblastoma, if I talk about, it is a tumor that is going to involve the olfactory nerve. We all know they are going to pass through the cribriform plate. So what you can see that you are going to see a dumbbell shaped tumor. A dumbbell shaped tumor will be seen in esthesioneuroblastoma. Part of the tumor will be seen above the cribriform plate and a part will be seen below the cribriform plate. Investigation of choice for localization of parathyroid adenoma, that will be a Cysta BV scan, right? So basically your oxyphilic parathyroid adenoma, that is going to show increased uptake on the Cysta BV scan. Just remember another important indication of Cysta BV. So Cysta BV will show increased uptake in cells with increased number of mitochondria, and that is shown by cells of the myocardium. They are going to show increased number of mitochondria and they are going to show increased uptake on the Cysta BV scan. So this Cysta BV scan is used for myocardial perfusion imaging. So two important indications, one is parathyroid adenoma and the other is your myocardial perfusion imaging. Identify the MRI sequence. So whether it is a susceptibility weighted imaging, whether it is a proton density, whether it is ADC or gradient decay. So guys, whenever you are able to see black dots within a brain image, just think about a susceptibility weighted imaging. And we talked earlier today about the diffuse axonal injury, right? So diffuse axonal injury will have a similar appearance like the one shown here. You will see that there will be an SWI image, and within the susceptibility weighted imaging you will see blooming foci scattered within the brain parenchyma, predominantly at the site of grey white matter junction, right? So a 65-year-old male, history of AF, presents with right-sided hemiparesis. Random blood sugar is 106, NCCT is normal. Next step is, what is the next step? So guys, all patients with history of stroke, investigation of choice will be your MRI, right? So MRI is one investigation in which the diffusion weighted sequences they can pick up the infarct as early within half an hour. So what happens in a patient with acute infarct? You will see that the acute infarct will appear bright on diffusion vivid images. Acute infarct will appear bright on diffusion vivid images. And if I talk about NCCT head, an acute infarct will appear normal. Okay, a normal on the NCCT head. So you are going to go for MRI. And if there is no hemorrhagic infarct within this patient, what you are going to go further? You will go for thrombolysis, right? So we should know important imaging findings of acute infarct on NCCT head. So what happens whenever there is an acute thrombus within any middle cerebral artery? Okay, that is going to appear bright. So there are various signs based on the vessel that is getting thrombosed. So if the M2 segment of middle cerebral artery it is getting thrombosed, it is your dense MCA sign. If the M3 segment is getting involved, that gives a sign that is known as Sylvian dot sign. So if there is any posterior circulation stroke, you will see an infarct that is involving the cerebellum and occipital lobe. You will get a dense basilar artery sign. Dense basilar artery sign will be seen. And sometimes you will see that there will be loss of gray-white matter differentiation at the insular cortex, and that is known as loss of insular ribbon cortex. Loss of insular ribbon cortex. So these are important signs of acute infarct in a patient with on NCCT head. So guys, first of all, you should know what is the investigation that is being shown here. It is a CT angiogram of bilateral lower limbs. And on this CT angiogram image of bilateral lower limbs, what we can see, ergotamine was prescribed for migraine attacks, and we all know that ergotamine, it is a potential vasoconstrictor. So what is happening in this patient? If you look at the vessels, so guys, let me just label the vessels for you. This is the common iliac artery. Then this common iliac artery continues as common femoral artery. Then common femoral artery divides into two, that is the deep femoral artery and superficial femoral artery. Then this superficial femoral artery continues as popliteal artery. This popliteal artery divides into two, that is your anterior tibial and posterior tibial artery. So here in this patient, what we can see, that both these arteries of the leg, that is your ATA and PTA, they are not visualized. It means that there is a vasospasm, there is a vasoconstriction of the ATA and PTA, and the most likely cause will be your ergotism. Okay, if I talk about atherosclerosis will not be seen in a patient with 25-year-old age, right? So atherosclerosis is going to happen in patients in more than 50 years of age, right? Polyneuropathy and radiculopathy, they are not going to have any imaging features. No imaging features will be seen on CT angiogram image. Okay, the vessels will be completely fine in any disorder that is going to involve your nerves. A 48-year-old lady presents with right upper quadrant abdominal pain. Ultrasound reveals multiple GB calculi but no wall thickening. Alkaline phosphatase was high. Glutamyl transferase 5 times increased. Other parameters are normal. right? So CBD is measures 12 mm. So guys, normal caliber of CBD is less than 6 mm. So now in this patient we have been told that CBD is dilated. So what will be an important cause for CBD dilatation in patient with GB calculi? So that will be due to the passage of the calculus from the gallbladder into the CBD. So the most important cause will be your choledocholithiasis. And also your liver function test, they are giving you an obstructive feature. Your levels of alkaline phosphatase, they are high. Your gamma glutamyl transferase levels, they are also very high. So when they are high, they are going to point out to any obstructive pathology. So you are going to think of choledocholithiasis, and I told you for imaging of the biliary tract, the most important investigation will be your MRCP. MRCP is the investigation of choice. So a 35-year-old female presents with pain abdomen on post-op day 5 following laparoscopic cholecystectomy. Ultrasound shows a collection in the right upper quadrant, right? So this is just your similar case of CBD injury, right? So there is a collection in the right upper quadrant, your Morrison's pouch. You are going to go for MRCP abdomen to look for any bile duct injury, right? Identify the structures that are marked here. So here in this image you can see that the structures that are marked here, this is your anterior ethmoidal canal, which is being shown here, right? This is your frontal sinuses. We have already discussed the anatomy. This is your frontal sinuses. This is the cribriform plate. This is the middle turbinate. And if you have a look at the middle turbinate, you will see that there is pneumatization of this middle turbinate, and this pneumatization of middle turbinate is known as lamella concha. This is your inferior turbinate. This is your maxillary sinus. This is your maxillary ostium. These are the important structures of the PNS. Identify the modality shown here. So what have been shown to you? CT images have been shown to you, and within the CT images you can see that there is also contrast. A contrast can be seen in the renal pelvis and the ureters. Contrast can be seen in renal pelvis and ureters. So this is a case of, this is what is the investigation which is shown here. This is CT urography. This is CT urography. What is the likely diagnosis? So guys, we have been given an ultrasound image of the fetus. Ultrasound image of the fetus has been given to us, and here we can see that this is the abdomen and chest of the fetus. Abdomen and chest of the fetus. This is the face and head region, right? And what happens in a normal fetus, you will see that bones, they are going to appear hyperechoic. And if you look at the fetal skull, you will see that the fetal skull is absent. Fetal skull is absent, and this absent fetal skull will be seen in a patient with anencephaly. What is the appearance? Name of the appearance that you get? It is the frog eye appearance. What are you going to see in a patient with omphalocele? Omphalocele, you are going to see that there will be herniation of loops through the umbilicus that will be covered by a membrane. So you may be able to see an outpouching at the level of abdomen. that will be seen in a patient with omphalocele. If I talk about cystic hygroma, you will see that the nuchal translucency that is going to be increased. The anti-NV scan that is usually done between 11 to 13 weeks, you will see that NT will be increased in these patients. A 5-year-old child with intermittent pain presents with falling chest X-ray. What is the likely diagnosis? So here in this X-ray you can see that air fluid levels can be seen behind the cardiac shadow. Air fluid levels can be seen behind the cardiac shadow. So that is usually seen due to herniation of the contents from the abdomen into the thoracic cavity. So that will be a case of Morgagni hernia. A child presents with cyanosis, it means it is a cyanotic heart disease. His chest radiograph is given below. What is the imaging appearance of this heart? It is having a boot shaped heart, Corin Sabo appearance. So this boot shaped heart, this is seen in patients with tetralogy of Fallot. What are the 4 things that you are going to see in patients with tetralogy of Fallot? You are going to see a VSD, subaortic VSD, right ventricular hypertrophy, overriding of aorta, and you are going to see pulmonary stenosis. In Epstein anomaly, you are going to see a box-shaped heart, associated with lithium use in females, lithium use during pregnancy, right? There is downward displacement of tricuspid valve in which the right ventricle appears hypoplastic. Transposition of great arteries, you are going to see egg on string appearance. In TAPVC, you are going to see snowman appearance, right? So guys, these were few important questions. From the INICET, right? So what I'm going to advise you for INICET, revise your previous year questions, right? Then revise your entire syllabus, revise your notes at least once in the last 15 days before the exam, and keep on giving grand tests, at least 2 grand tests per week, right? And don't worry too much, just keep on giving your best, right? What is most important is that you keep on studying, you keep on giving your best, you don't take too much stress about the exam dates, about the exam coming near, and you keep on giving your best, right? This is what is most important. So thank you guys, I hope you got some insight from these previous INICET questions. Till then guys, bye bye, take care, keep it.